Okay, welcome all. It's Tim Richter here from the Canadian Alliance to End Homelessness on behalf of the Canadian Shelter Transformation Network. I'd like to welcome you to our webinar with Iain DeJong of OrCode, harm reduction and housing focused shelter is our topic today. Quickly, just to go over the agenda, we're going to have I'll just do a quick presentation and a bit of housekeeping, and then we'll launch right into a presentation by Iain, followed by a question and answer period and a quick closing. Just so you know, everybody on the line is muted. We have a lot of folks on the line. We don't want could get quite noisy, so we've muted everyone. Please use the question and answer tab to ask questions, but feel free as well to use the chat function to share comments and speak to other participants or to the panelist. I'll be keeping track of the chat and the Q&A if anybody for any questions. We will be posting a recording of this webinar at transformshelter.ca under the webinar tab for anybody who wants to access a recording afterwards, as well as the slides from Iain's presentation. So without further ado, I'd like to introduce my friend Iain DeJong. Iain, most of you will know well at this point, so I don't need to go through his bio in any great detail, but suffice to say, Iain is one of, if not the North American expert on shelter transformation. He's done work all over North America on this topic, perhaps even further afield. So we are very lucky to have him. Also want to thank the Government of Canada Reaching Home for the funding to make this webinar possible. And with that, Iain, I will stop share, pass it over to you, and listen and learn. There you go.
Thank you, Tim. And just a quick check that everybody can see my screen. Thumbs up, Tim. All right, good. Well, good day to everybody. Afternoon for some, morning for others. It really is my great pleasure to be back at this part of this webinar series looking at housing-focused shelters and different aspects of housing-focused shelter that we can consider in our policies and our procedures, our practices, and the people that we serve. I would also like to take this opportunity to welcome everybody to the webinar today. Those of you who fund shelters, executive management level of shelters, frontline workers within shelters, people with lived experience who have been recipients of shelter services in the past, volunteers, others who have a keen interest in making sure shelters are places of transformation in people's lives. Most welcome. Tim did, I think, a very excellent high-level introduction of me. Just to tell you a little bit more about OrCode, the organization I have the privilege of leading. We do try to do homeless system transformation, and we do very large-scale transformation, like an entire community, and sometimes very large urban centers, right through to rural environments and even remote environments. We do a lot of work on leadership development in homeless services, and we provide technical assistance predominantly around things like shelter transformation to be more housing focused, work in street outreach to be very solution focused, and things like assisting with supportive housing supports, programs, and evaluations. We try to be catalysts for better outcomes across the entire OrCode team, and we try to advance ideas. So a space for communication and dialogue. We try to create and share resources and offer training that at least hopefully doesn't suck. What I want to cover in the approximately 40 minutes or so before we get into question and answers, the working definition of harm reduction, lower barriers to shelter and how that relates to being housing focused, safer spaces with supports, harm reducing approaches that we can consider in housing focused shelters, and concluding with some thoughts on a focus on housing and appropriate supports. So I start with this idea of a working definition of harm reduction because one of the things that happens in the space of talking through harm reduction is there are different definitions. There seems to be the absence of one universal definition that everybody has agreed to. That's not to say there aren't some very good definitions out there. And there are a good number of principles that underline the work in a framework within which we can consider the application of harm reduction. So I'll start with a general definition, which isn't specifically to substance use, isn't specifically to sex work, looks at a broad range of different types of activities. This comes from Positive Living Society. Looking at it as a public health response, I think that's very important, that we kind of anchor our understanding of harm reduction within a public health response with the goal of keeping people safe and minimizing death, disease, and injury that results from higher risk behavior. What we want to do is make sure that we're very much anchoring our engagement in outreach and education to specific populations, and in doing so emphasize the ability of the individual to care for themselves. We want to educate on risks of specific behaviors, provide education on treatment resources and prevention resources, and provide materials that can lessen the potential for harm. Now, I highlighted the points related to things like education, treatment, and prevention because this is where some of the pushback against harm reduction starts, and it's usually from a place that is misinformed or underdeveloped in people's thinking through the practice. That we can be in a position where harm reduction and treatment and prevention are part of coexisting pillars in a response to substance use and other harmful behaviors, and potentially harmful behaviors. And if we think about harm reduction in this space, what we're really saying is if we're meeting people where they're at, we have the ability to engage in those education conversations, in opportunities to talk through things like reduction, and for those who are interested to talk through elements of treatment options with the assumption that treatment isn't one size fits all. In the harm reduction approach, risky, in quotes, behavior does not have to stop. So we're not going to be in a position where we start in the delivery of shelter services or on the pathway towards housing services with people to say, we will only shelter you if you stop engaging in this high risk behavior. We're not going to say we're only going to put you on a list for housing or assist you in the housing search or provide supports to you in housing if you stop. Instead, what we want to do is modify the approach to the behaviors. And so people can engage in their particular behavior and engage in the community in a way that is reducing the harms associated with that behavior to themselves and or to the broader community, all the while respecting that it's an individual's autonomy to choose to be engaged in certain activities. So there's no forcing people to engage in a particular way or to stop using, etc. Within the substance use realm, I like this definition from the Canadian Mental Health Association, reinforcing the evidence base, which I think is really important, that there's a fair amount of data and literature that exists in the space of harm reduction that is very much client-centered, or we might say person-centered or guest-centered approach, really trying to focus on how do we work from the person's strengths and how do we build out from their experience. That'll inform things like our practices, our procedures, and our policies. Reducing both the health and social harms associated with addiction and substance use without requiring people to abstain or stop. What it includes is programs, policies, services, and practices, and choice of how people engage and how we look at minimizing harms through this idea of being non-judgmental and non-coercive. So really being present in that space and meeting people where they're at means that we have to be open to validating the experience of the individual and putting things into a context of what we're hearing and understanding, so that we're not in a position where we're thinking, oh, something really wrong with this person. That's not this at all. This is really about understanding what may have happened to the person, how they led to these decisions in their life, deepening our rapport with individuals in such a way that we can promote reductions in harm. It's predicated on this idea of meeting people where they're at. That can happen both literally and figuratively. So we think about that in terms of being present with people in the spaces of engagement. So not hiding in offices, those sorts of things, but also understanding that people are going to be in different emotional states, spiritual states, behavioral states, have different senses of community, have different health issues, etc. it's been proven that those who engage in harm reduction services are more likely to engage in ongoing treatment as a result of accessing these services. I think when we think through this, we don't want to oversell on the one hand, but on the other hand, we need to be conscious that if we do have this non-judgmental engagement right from the very beginning, we can get to a place where people will explore other reductions or alternatives to their use and the impacts. And as it relates to shelter, I also wanted to highlight that we can look at a definition of harm reduction as it relates to sex work. And this comes from a particular article within the Lancet from 15 years ago. Still useful in terms of a construct for thinking about reducing harm amongst people participating in sex work. But really taking those same harm reduction principles and using it to try to safeguard sex workers' lives. So decreasing exposure to serious harms, and then looking at a range of strategies like education, empowerment, prevention, occupational health and safety, human rights-based approach, peer education, etc. We can say that any approach to providing harm reduction services, whether it's in a shelter, in housing, through street outreach, etc., is going to really be anchored into these 5 different aspects that inform our approach to engagement and inform our approach to service. So starting at this top, this idea of respect, that we see the wholeness of the person, we focus on whole person wellness. We actually respect the fact that people have different histories, different stories, different decisions. We respect individuals' autonomy. We respect the decisions that they make based upon the knowledge that they have and access to resources that they have. And we don't look down upon people as a result of their substance use or participation in sex work as 2 types of harm that interact or intersect with the population we serve in shelters. We accept that people are making decisions in their own life. We accept that it is their decision to participate in the behaviors. We accept that they are the decision maker. We accept that they should be empowered. We look at empowerment then as the ability to provide people opportunities as well as skills and strategies to self-advocate. We do this work from a place of compassion, so being really conscious of things like power dynamics, not seeing this as a relationship between healer and wounded, looking at this really from a perspective of journeying with people. And it's collaborative. There's a fair amount of mutuality that goes into any engagement in harm reduction. So we're not forcing people or coercing people to participate in any sort of practice, but rather we are working with people to educate, inform, and allow them to make decisions relative to their engagement with harm reduction practices, up to and including advancing from shelter into housing. There are a handful of guiding principles that underscore harm reduction and substance use. The first being, we focus on what is pragmatic. Another phrase that I've heard many times in my career is about harm reduction is it's often not what's pretty, it's what works. So looking at, from a pragmatic perspective, what are the most immediate and tangible harms of the substance use? How can we actually reduce those immediate and tangible harms in such a way that are very much person-centered and appreciate, understand the strengths of the individual and the opportunities to engage with them in those services? It is focused on harms. And what we're trying to do is reduce harmful consequences of use to the individual and society. So that could include things like change in substances used, change in the mode of use, change in the frequency of use, change in the location of use. Again, focus on immediate and tangible harms. Prioritization of goals, which happen at that individual level. And I might even go a step further to say that many of the people that we engage with speak in the language of needs before they speak in the language of goals. And so our engagement with those persons has to very much focus on, at an individual level, what can we do to reduce the most immediate harms before we get into the longer term future-oriented goals, which is why things like having lower barriers in shelters is so important to be housing focused and to continue to practice harm reduction. To respect the individual decision is a personal one, and that does come with responsibility. And finally, there's a flexibility and maximization of intervention options. So we consider these at the individual level, not at the shelter-wide level, not at the system-wide level, but at the individual level, so that the individual can start to make informed decisions around which actions they want to take in which orders relative to his, her, or their specific aims associated with their substance use. Harm reduction in practice requires person-centered design. And the 4 Ps of person-centered design: policy, procedure, practice, and people. We often think of that as hierarchical, and in many instances, it's also designed hierarchically. That it starts with the policy, then we figure out what are our procedures going to be in shelter, and then we see if staff actually engage in those practices and guests engage in those practices, and that impacts the people who actually use our services. We might be well served to think of this as a multi-directional flow of information and the opportunity for co-creation in these spaces to make sure that shelter environments operate in such a way that they can be harm reducing while still staying focused on helping people reduce and end their homelessness. So reducing lengths of stay, reducing the volume of people experiencing homelessness, as well as focus on not just access to housing, but maintenance of housing. And to practice harm reduction well, we have to see strengths, both the individual strengths and the environmental strengths. And so our process of engagement with people when they come into shelter starts with this idea of discovery and appreciation as part of assessment. So not using assessment as the mechanism to see deficits, instead seeing assessment as an opportunity to identify strengths, to see capabilities, qualities, talents, skills, aspirations, and to then figure out, what does this look like to you in the future? So this idea of envisioning a future that is one that we want to stay somewhat anchored in the thoughts around housing, as well as reductions and harms associated with any practices or behaviors in their life that are causing harm, and then figuring out, how do we take action in this? And so this idea of co-constructing design is really focused on mutuality and collaboration. What can we do? What will they do? How do those pieces of the puzzle come together? That's everything from specific practices related to reducing harm through to practices and techniques and strategies we use to help people access housing, and then focusing on sustaining destiny, which is destiny being the variation of the vision, that it's the place that they want to be, so that we help people not only achieve the aims of reducing harm and accessing housing, but also sustaining a reduction in those harms and access to housing. In the harm reduction approach to sheltering and focusing on meeting the needs of the individuals and families and couples that use our shelters, we have to be able to engage in such a way that we're demonstrating interest in providing assistance, in helping them exit their homelessness and helping them reduce harms. We have to use reflective listening, and so that people know and have been validated that they've been heard and understood. We should try to empathize. This is something that is done remarkably well by trained peers in this space, but that doesn't mean that other staff who don't have lived experience with homelessness and or substance use can't try to enter into a space of empathy with people. We want to validate people's feelings about the process, and when it's appropriate, also validate their behaviors, and then communicating with people the reasonableness, meaningfulness, and effectiveness of their considerations in the process relative to reducing harm and moving towards housing, and making sure that we're seeing the person as they are. If one of the core intentions of housing-focused shelter is to maximize opportunities for individuals and families and couples to move from shelter into housing, we have to take a look at whether or not our shelters are spaces that are open to working with people who may exhibit behaviors that otherwise were deemed to be problematic or a disturbance. And there's all sorts of language, sometimes it's code language, that's used to describe certain guests in that particular way. But to be really clear, we're not trying to use our housing focused orientation of our work to become a barrier in and of itself. So it's important that we're transparent with individuals, couples, and families who come to access our services, that we want people to look at safe and appropriate alternatives if they can. We want people to try to self-resolve if they can. We want people to engage in our coordinated access process as it's appropriate, or to seek out other opportunities to be housed outside of coordinated access that don't require jumping the queue or side doors. And if we think about that, how we position housing as the goal of the sheltering experience is really important. Otherwise, we're establishing a potential barrier right at the time that people first get to us. And so we might be transparent in the space of saying, we want to be housing focused. We want to help you achieve housing. We want to make sure your length of stay is as short as possible. There's nothing wrong with being transparent in this place. We can say yes and. Yeah, yes, those are intentions, and there's some work that we can do to improve our shelter access for people, to make it a space where otherwise vulnerable people would be staying outside or in unsafe conditions, doubled up, or in their cars, or those sorts of places. If we want the opportunity to get people into the process of getting access to housing, we have to make sure that we are open and receptive to a broad range of behaviors and experiences coming to the shelter door. So one of the things that we look for is whether or not there's a commitment to harm reduction within the housing focused shelter itself. Is it understood? Is it practiced? Is it supported in both policy and actions? Is it reflected in values and principles of the organization? And is that an aspiration, or is that real? This is where there's sometimes a disconnect when we use the language of saying that we want one thing, like very vulnerable people to have access to our shelter, to focus on accessing housing and ending their homelessness, those sorts of things. But then as you peel back the onion, you start to see, well, there's a whole bunch of things that are happening that might be counter to those particular values or principles sustained, and whether or not housing is used as a strategy to help reduce harm for many of the people served. We want to make sure that we're focused on behavior, not on use, right? And so what happened historically in more of a traditional sheltering model, and thankfully much of this has been taken out of the Canadian context now, but we used to focus on, have you been using or not? And if you had been using, then in some communities, in some shelters, I don't want anybody to think this is universal, but in some locations we say you can't come in because you've been used. Not you can't come in because your behavior is disruptive or because you're too unwell. There was none of those sorts of analyses done. It was very binary. You've used, therefore you can't come in. Really reorienting, and this is what we've seen in the past couple of decades, I think, really well in this space, is saying actually the focus has to be on the behavior, not on the actual substance use. That we can work very effectively as time and staffing, resources, and training allows, to focus on modifications of behavior and modifications behavior in engagement that will allow for smoother encounters. So that absolutely in some instances is going to mean meeting the most immediate needs relative to having a safe place to crash for that, and then following up with housing conversations when the person is in a state that they'll be more engaged in that conversation. We want to also identify blind spots and barriers. And this is where pulling together a coalition of guests, staff, volunteers, community partners, other people that engage with your shelter, to really be asking questions like, do we have any service or entry requirements that are too restrictive and don't need to exist or can be relaxed? In other words, are we making it too hard for some people who may be engaged in harmful behavior or higher risk behavior? Have we made anything happen in our service requirements or entry requirements so that some of those individuals can't get into our shelter at all? And if so, then that careful examination, does this still need to exist, or can we actually change this, or can we relax this? Looking at your rules and expectations and whether or not any of those need to change. This is remarkably well done, especially if we include our guests in this process. They often can see some things in our rules or expectations that we didn't see, or that we didn't intend to be seen, or is interpreted by staff differently than the intention when it was first written. that is creating barriers of access to shelter services and therefore impeding our ability to work on helping people access housing. And we also want to look for any Marvin rules, a concept I've talked about in other of these webinar sessions. But this idea of Marvin rule comes from my friend Cynthia Gendra. She talks about the fact that most shelters have one or more rules because a person who we'll just call Marvin did something, and therefore you create a rule that's now enforced with everybody, even though it was one outlying situation that probably could have been dealt with without requiring a rule. But those sorts of things can create barriers to access to service over time if they're not kept in check. Thinking through things like, are we re-entering people at the best time of the day? So if you think about how people go about their day-to-day activities and routines, how people have their needs met throughout the course of the day, are we creating an environment where actually, for example, we have unintentionally set up an environment where it's really difficult for some people to access? So example, some people who use or are participating in sex work later in the evening, even into the early morning hours, and we might have had a hard and fast rule that people have to be back by a certain time. Could we explore ways of people letting us know in advance and us actually modifying opportunities for people to re-enter? What impact would that have on the entire shelter operation? What impact would that have on staffing? Those are the sort of things we want to consider. There's no easy answer on those, but it's worth consideration. Is there an easy way for people to get to our shelter? So one of the barriers and blind spots is you can have the greatest harm reducing housing focused shelter and nobody can get to you. How do we look at things like that? And do we have anything that might be off-putting to people of different beliefs or no beliefs? I want to be really clear on this point because it's sometimes been misunderstood or mistaken when I've spoken. Some of the best shelter operators in the country are faith-based organizations. Some of them are the most innovative, the most transparent, the most housing focused. And there are other shelters that in some instances was completely unintentional, where they've created an environment that people don't feel safe because of the projection of beliefs onto others. So just being sensitive to and thinking through those particular parts in the built environment. We have to think through who gets access. And the best way to do this, I have found in conversations with shelter to try and be more harm reducing, to lower barriers, to focus on housing, is to reorient the conversation towards who did you prioritize for your most intensive services in coordinated access. In most communities, that has been articulated as people that have been homeless for long periods of time, often with co-occurring health issues, often meeting definitions of chronic homelessness, often with higher acuity, however that is framed or decided in the community, amongst potential other barriers or other prioritization. And where the barriers come in is when there's a disconnect between who we said we wanted to be the top priority for some of our most intensive services and who gets into shelter if the people that really need the intensive services can't even get into shelter. And so starting to think through that lens leads a bit of a spotlight on changes that we either have to make in coordinated access prioritization or changes that we make in terms of who we're really targeting or trying to make most welcome the space of shelter. One of the things that shelters have found very helpful in many of the communities we've had the privilege of working is having shelter staff go out with outreach teams where outreach teams exist in the community, where outreach teams don't exist in the community, in instances going out independently and talking to unsheltered people, rough sleepers, and asking them directly what it would take for them to use shelter or why they don't use shelter or how they can do better in shelter. That this idea of hearing the voice of the expert in that space can lead to places of reflection around things like changes in policies, practices, procedures, or the work that we do in shelter, can result in changes in messaging of how we go about engaging with people, can result in changes of how we want to do street outreach, can also provide opportunities for education. What people think and what actually occurs might be different. So how can we modify in this space? And then debriefing with shelter guests on their experience of intake. Do you feel that this is a safe space? Do you feel that this is a space that actively engages in conversations around housing? Do you feel that that was made clear during the intake process? Do you feel that we're harm reducing? Do you feel that we have low barriers? How can we assist you and support you in meeting our expectations? So debriefing from that experience of intake is also very helpful. And then we want to enter into the space if we truly want to reduce harm and be lower barrier while focusing on housing, looking at service restrictions and barring and banning. And the main reason for doing this is it's not to say that we want to completely annihilate service restrictions, barring or banning. We need to carefully examine it, and we need to make sure that it makes complete sense still in the context of trying to reduce harm and in the context of trying to help people exit from homelessness into housing. So one of the ways that we can do this is to look at your existing data. If you record when service restrictions, and I'm using the word or the phrase service restrictions, any form of modified service, like you can stay here, but you can't come back here till like 11 o'clock at night and you have to be gone by 7 o'clock in the morning. That's a restriction, right? You're not allowed during the other times of the day, as well as barring and banning any form of denial of service for 1 or more nights. If you look at your data, you can start to see what some of the most frequent causes were for service restriction and barring or banning. And you can see from looking at those causes, if there's any policy, procedure, or practice that could be put in place that would decrease that particular reason generating so many restrictions and barring and banning whenever it is safe and appropriate to make those sorts of modifications. And what I'm really getting at here is when some shelters have done this analysis, they thought, or their hypothesis was, it's only in the most severe safety-based situations where we get to a place of service restriction or barring or banning. And then they look at their data and they kind of realize actually it wasn't those things. It was something completely different from that. And some instances, very petty type infractions is the sort of language that's used, which also is usually indicative that people are policing behavior as opposed to supporting people to meet expectations. Do more of these occur when you're looking at your analysis? Are there certain service restrictions that seem to happen at a certain time of the month or a certain time of the year? That really is helpful, particularly when there's behaviors associated with substance use that seem to be disruptive, and you find that your service restriction volume goes up during times of the month when people get access to any form of income assistance in your province or territory. We might want to look at changes in staffing during those times of the month, or we might want to look at, when we have a higher volume of people who may be engaged in more harmful behaviors at a particular time, do we actually have intake processes that appreciate that? Do we have engagement processes when people are in the space that support that? Sometimes it's the same staff person that's involved. And so it's illuminating, not in a punitive aspect, right? I'm not saying we go out and fire people, but maybe it's that staff person needs more tools in their toolbox to allow them to de-escalate situations. It might also be interesting to know if more of these occur when there isn't an extreme weather event, because a lot of shelters have protocols for extreme cold weather alerts or cold weather alerts, or it goes by different phrases in different parts of the country. But many of those shelters are remarkably accommodating to individuals that are engaged in behaviors that deemed to be higher risk during those weather events. And then it makes you wonder, well, could we build upon those strengths and those strategies and those techniques during other time? And what guests or what are the commonalities amongst guests that are most impacted by service restrictions and barrings? And then we get to a place of looking at amendments, again, for the purpose of reducing harm, lowering barriers, being in a position where we're allowed to work with people more continuously towards the goal of housing. So really saying, why do we do service restrictions or barring and banning? Is it about punishment? Is it about rehabilitation? Is it about compliance? Is it about safety? Is it about service? Like, what is this thing? How do we make sure that we're moving from this idea of policing infractions, I caught, you wouldn't believe what I saw, those sorts of things, to here's the support opportunity to help this individual or couple or family meet our expectations and still be able to stay within a shelter environment. Avoiding behavioral contracts. So that idea of 3 strikes and you're out. Looking at different approaches that still support people to meet behavior without saying, look, if you do this over and over again, you're going to be out, because quite honestly, some people have cognitive impairments that would make it impossible for them to flip the switch to meet the requirements in that behavioral contract. So different approaches of support. Really looking at, does your organization really need to have any lifetime bans? Even when people have done some really egregious things by the perspective of shelter staff or the organization as a whole. And if you did, do we make sure that they still have access to other shelters in your community if you have more than one shelter? But really thinking through that in the context of, if you are a one shelter community and you say that someone can never come back, what does that really mean? And then the last thing that I would suggest in amending service restrictions or barring and banning is asking guests, both people that have been service restricted and people that have been not, their impressions and suggestions for how to improve that process. Love this, borrowed from the Calgary drop-in. This idea of also doing a bit of a pre-screen before issuing a service restriction and having staff kind of go through this own checklist to make sure that they're in a good place when a service restriction or a barring or a banning has to be put in place. And this sort of process is making sure they're very mindful and thoughtful in the process, and also ensuring that, you know, we're looking for the best possible outcome for the individual and the organization. One of the things that I've learned through several years of helping shelters through the transformation of being more housing focused and ensuring really vulnerable people can stay within shelter in order to access housing and don't lose that continuous approach towards helping people in housing, is also saying, what's the minimum length of time you could provide some sort of restriction? And I've found great value in things like seeing shelters implement 10-minute timeout sort of periods, right? Some of the same shelters say, well, once upon a time, if someone did X, we would have said you had to be out for the entire night. And now we're saying, if you do X, 10 minutes, go for a walk around the block, come back, let's try again. So those sorts of processes of engagement, just giving people the time and space to clear their heads in their engagement. From a harm reduction perspective, we also need to look at safer spaces with supports within the shelter environment. So doing things like the core services really well, access to food, access to a bed with clean linens, access to a towel, doing walkthroughs, monitoring that people are okay, greeting people by name. Those are all great core elements of the service delivery, continuing to do that. One of the other things we can do from a dignity perspective in reducing barriers that allows for more engagement is, whenever possible, minimizing or removing the needs of guests having to ask staff for basic items. So you might think through things like, you know, could I provide access to soap bars and people could just come and grab their own soap as opposed to needing to ask staff for soap? So, you know, that sort of dignity related piece. If they're providing harm reducing supplies, decreasing stigma associated with access. So making it at the same space you engage with staff about any opportunity for engagement with staff, as opposed to you've got to go to a special staff person in a special room down the hall, and making sure that access to education supports are readily available. From the safer sleeping space and support perspective, we have to think through where and how people safely crash. So is that a specialized mat program for some individuals? Perhaps different shelters in the country have done that remarkably well. Is it, for example, taking the mattress even off the bottom bunk and putting it on the floor for some people in particular situations? That is very helpful. Access to the restrooms. So some shelters have thought through, okay, people who have been using certain types of substances are more prone to nausea or diarrhea. And so we want to make sure that they have the easiest access. So we reserve our beds or our mats that are closest to the restroom for those individuals. Additional considerations, environmental concerns, and I'm not trying to be gross or graphic here, just some really practical things that we've seen put in place. So if people are struggling to get to the restroom, you know, having buckets, or if people are soiling themselves and that's causing disturbances, you know, or issues with staff engaging in maintenance and good hygiene practices, rubber mattress covers, wipes or face cloths, so people can actually clean their face without having to use their shirt if they've been ill, access to water and making water bottles available or snacks available, and even having staff bring those things to the places where people are sleeping, making sure people have access to a change of clothes without having to ask for a change of clothes. And then staff training, right? So making sure staff are trained on how to support people in considering safer positions to sleep. How do you do breathing or wellness checks throughout the shift in the middle of the night for someone who's been using, when to call 911, de-escalation, a lot more training related on the implementation of those than we're going to get into in the webinar today, but making sure people are in that space. And then give thought to how can washrooms be effectively supported, especially if washrooms are a place where a fair number of injection substance users may go to use. So how do we support people who use washrooms without being too intrusive in letting people just do their business? Access for people at different hours of the day, which I kind of touched on before. Allowing people to go out for breaks at night for a predetermined length of time. So things like someone who needs to use at 2 o'clock in the morning could go use off property and come back without there being a lot of rigmarole. Safer disposal throughout the entire facility for, in particular, people who use needles, and how and when staff engage with individuals. And then a variety of harm reduction approaches, very practical things that we can consider in shelter operations. And I'm just going to touch on these. I'm not going to train on all of these today, but thinking through everything from harm reduction and engagement. So can we get together an advisory group, current and past guests, who can help inform our thinking around these harm reduction practices within our particular shelter? Who are the allied professionals that we can bring on site, and under what conditions would we bring those allied professionals on site? How do we make supported and informed referrals? And most of your systems of support outside the shelter are also going to have waiting lists and those sorts of things, but we still got to know when and how to make referrals, and then framing housing as another approach to assist with reducing harms. So in this regard, we also say one of the best strategies we can use is making sure that staff are trained on the different substances that people are most frequently using amongst the population, so you understand behavior and different ways of communicating and de-escalating with people, and kind of the general run cycle of how long people have been using, how long it will impact behavior, those sorts of things. And then we look at these emerging, promising, and best practices. So some of these you may do, some of these you might have done in the past and stopped doing, some of these you might have considered doing and haven't done yet, some of these might be new to some of you on the webinar today. So things like access to safer use kits or works kits. I've seen this in different parts of the country, particularly for people who are injection substance users, who in one like paper lunch bag can get everything that they need safely. And it's, there's no stigma attached to when people ask for it, and how they engage with staff for it, those sorts of things. Needle distribution or needle exchange, which might be separate and apart from any sort of other harm reduction supplies that are shared. And I think distribution is probably where we want to be, but accepting that some jurisdictions are more interested in exchange. Condoms and dental dams. Condoms are pretty frequent. I'd see a lot of even, just grab what you need sort of condom access in shelters, but making sure that we continue those sorts of practices and ensure that dental dams are available as well. Amnesty totes or safer storage being used in an increasing number of shelters, a place for people to safely store whatever they bring into shelter. It doesn't have to be alcohol or other drugs, but they could put important papers there, they could put money there, they could put their harm reduction supplies in there, they could put whatever they want in there. And the whole point is, when you come in and you have a safe place to store things, it decreases the likelihood of people, for example, feeling they need to binge use, like finish the entire bottle before they come in. If they knew they could safely store their bottle and get it upon exit, maybe they would use less before they come in, and that might also decrease the impact to the person and impact to the shelter operation as a whole. Voluntary trusteeship programs, mixed feelings about this one in a shelter environment, sometimes better in a community environment, but to help people manage their money and to be in a position where they can think through things like paying the rent as well as paying for substances. Managed alcohol programs, well established in places like Ottawa and Toronto, and many other countries and parts of the country have worked on this as well, just naming two, but medically supervised, really intentional approaches to when and how people get access to alcohol, readily available sharps containers throughout the entire facility, extended curfews or day sleeping for participants involved in sex work, night breaks for substance use off property. I've kind of talked about that. Even a lot of places have smoke breaks, but is there any other time of day that we would allow people to leave and come back? Some parts of the country have worked on things like safer injection sites being co-located or trying to plan on that, although with a lot of the different provinces kind of balking or re-examining that, we'll see where that goes in the future. All staff trained and equipped with naloxone, and rolling papers for those who collect discarded cigarette butts. Very simple, small strategy. And these are not exhaustive by any stretch, but starting to think through what are the different practices we can put in place and why. And all of this should lead to a focus on housing and appropriate supports. So we have to be prepared for how you want to go about addressing some of the common concerns. So you'll hear things like, well, we focus on housing, but they're using so much that we'd be setting them up for failure. How do we then work on re-examining those sorts of statements so that people can be successfully housed and continue to use, hopefully with reduced harm in the future? People who say, I don't want to spend money on rent. Well, the reality is that we're working with people with very low income. We do need to straddle this reality of money to get through life and money to pay rent. And the money to get through life, which encompasses a broad range of things, which may include purchasing alcohol or other substances, is real. So let's have an honest conversation about budgeting and what it looks like that doesn't judge people and doesn't look down upon people and say, well, geez, I guess you got to stop using if you're going to afford a place to live. Most people who use substances have both in society. So what can we learn from that experience? This sentiment that when people are feeling isolated, they either party or they leave their unit. We're worried about overdose deaths when people are by themselves, or we're worried about people inviting everybody they've ever met and then getting evicted, or we're concerned about people who are so lonely they'll come back to the shelter and use or engage in other harmful behaviors of the people that they used to know. So how do we create meaningful daily activities? How do we create community connection? How do we address some of those very real concerns? Landlords will never take our service participants. I think that's a judgment on our part, as opposed to how do we help people get access to housing. Sometimes you hear sentiments like there's better access to harm reducing education, support, and supplies in our shelters than when people move into housing. And that may be the reality when you started with. So it begs the question, how can we bring more harm reducing education, support, and supplies to people's homes? And, sometimes you'll hear things like, I can be in rough shape after I use, I don't want to be alone. So how do we help people create peer support networks so that they don't feel isolated and alone after they've been using? Housing does help reduce harm. These are not universal, but in many instances, it reduces exposure to violence and feelings of being unsafe. It allows people to better able to safely store alcohol or other substances, protect and appropriately manage their works, increase likelihood of reducing or even stopping if so desired. That's one of the key findings of the Mental Health Commission's at-home study. Better frame of mind, at least over time, there's less stress to consider safer changes in use, access to other community resources, improvements for self-determination as it relates to meaningful daily activities, and they can be more in control of when and how they use and where housing fits into the recovery process. And then for those individuals that are involved in any higher risk behavior for whom housing doesn't work, I think there's a tendency on our part at times to say, well, it didn't work because of the high risk behavior, as opposed to, yes, that might have been a contributing factor, but rather than saying, well, I guess housing will never work for this person, guess they're going to have to stay in shelter for a long period of time, reframing that inquiry, what can we learn from this process? What worked? What didn't work? Where's more support needed? Where are modifications and support needed? Where is frequency and supports needing to change? Did it make sense for you to be housed alone? Would you be better off with a roommate? Did you have good peer supports, community supports, etc.? Let's focus on the efforts that the individual made, as opposed to focusing on just the outcome of staying housed. What can we learn in a positive sense from this process? And then center a pathway forward on reinforcing the positives and worthiness, which would get back to things like coordinated access to say, if someone was prioritized for housing once, how do we make sure we don't lose their priority status if they've lost their housing, even if it was related to behaviors where more harm reduction education, support, or resources might have helped address that particular concern. And that is a very fast, high-level overview of harm reduction as it relates to housing-focused shelter, and we have time to take some questions or comments.
Right on. Well, thank you very much, Ian. Just a reminder to everyone to put your questions in the Q&A panel. We've got a first question from Nick. In your work with shelters aiming to reduce or eliminate service bans, have there been any particular practices that shelters have found particularly promising thus far, and or effectively connecting people who have been banned to other community services?
Okay, so on the first part, I definitely say, or reiterate, getting people who have experience barring or banning or service restrictions, as well as guests that haven't, involved in that process of looking through some of those reasons for you. Again, it's a different lens than how staff might look at it, or how management might look at it, or even how outsiders might look at it. So I think that can really help unearth some of the blind spots that we didn't see in that process. The connection to community-based supports, I think it's always going to be an offer, and it's always going to come down to where that individual couple or family is at in that process. Sometimes you can say, hey, look, you can't stay here, but we can get you a bed at Y or X or Z. And that is heard and understood, and we can do that sometimes. Other instances, I mean, the honest answer is people may be totally disengaged at that moment, and they may need some time to kind of think things through and re-engage. And we should be ready for that re-engagement in that process to other community supports and resources, maybe even doing some call-arounds to other shelters or community resources to see what's available on that night if we have the opportunity to re-engage with that person, couple, or family.
Okay. Just a reminder, folks, if you have questions, put them in the Q&A panel. Question here just about what are your thoughts on overdose prevention or supervised consumption in shelters?
So I think that overdose prevention for me is more than just responding when people have had an overdose. So, you know, if we even think about things like amnesty totes as an opportunity for overdose prevention, we've given people a safe place that it isn't known by staff, but is still up to the individual to not have to feel that they have to use other substances before they come in shelter, which is going to decrease the volume, or potentially decrease the volume of substances people are using, which is going to decrease the likelihood of overdose. I mean, there's those sorts of things, as well as having staff who are adequately trained in looking for the signs of overdose, who know when someone has gone into distress, in particular having troubles breathing or alertness, and what action to take, both in the immediate, in the moment, which usually things like administration of Narcan and calling 911, to, you know, what are the ways that we can even make sure that other guests are our eyes and ears of things happening within the facility so that we can respond more quickly. On safe injection sites, I think there's an opportunity for a place for safer injection sites within a shelter facility. I think that the challenge is going to be, and I don't have a definitive answer one way or the other, is it a resource for the entire community that happens to be co-located at the shelter, or is it explicitly and exclusively for shelter guests? And I just think when you think through the supports and management of that sort of opportunity or resource within a shelter, you'll have to think through those particular elements. And if you are going to co-locate it with the shelter, just making sure that your shelter is designed and resourced from a staff perspective to be able to provide the level of support that's necessary to do that in the safest way possible, which usually means other allied professionals also being part of the mix.
Well, you must have done a genius job of presenting, because there's no other questions in the queue at the moment. But Sandra Clarkson has joined us. Sandra is the co-chair of the Canadian Shelter Transformation Network, and just wanted to give her a minute or two to add some comment.
Hi, everybody. Sorry, I don't have any video capability today, but thanks so much for joining the webinar today, and really strongly encourage you to join the network. It has been immensely helpful for us here at the DI and working with Ian and his team. on that housing-focused shelter transformation, and we continue to be excited about sharing our learnings and doing that through this network. So again, strongly encourage you to join and stay tuned to the upcoming webinars that I know Tim is going to speak about in a moment. And thanks for your interest today, and hope to see you again. Thanks, Tim and Ian.
Right on. Thank you, Sandra. So we have a couple of more webinars with Ian planned. November 10th, dealing with resistance and being a housing-focused shelter, and December 3rd, what funders and program monitors need to know about housing-focused shelter. Both of those are coming up in the next couple of months. With that, thank you all for participating. Thank you all for your work in community and working to transform shelters around the country. I know that we're in the midst of an enormous global health crisis on top of a housing crisis, also dealing with an opioid crisis, and your work is extraordinarily challenging at the best of times. So thank you for keeping the focus on housing, keeping the focus on transforming your shelter and ending homelessness. Thank you all. Take care of yourselves. We'll see you again very soon. Thank you.